Welcome viewers. Dr. Joseph, gynecologist, fertility specialist. Welcome to our first segment of the many that we shall have. And in particular today, we shall be talking about a condition called polycystic ovarian syndrome. I'm sure some of you might have heard about it, some of you may not. But at the end of the session, I think each one of us will have picked something. So, welcome. So, what is polycystic ovarian syndrome? It is, sometimes we just call it PCOS in short. But if I put it in a layman's language, polycystic ovarian syndrome is a disorder which affects the woman's ovaries. And most of the time, it results in what we call an ovulation. An ovulation is failure to produce the egg to ovulate. So, for us to understand PCOS, there are things we shall need to get basics about. One is, under normal circumstances, each month a woman goes to her ovaries and picks one egg, what we call recruitment. So that egg starts growing immediately from the first day of her menstrual period. It starts small, usually about 2 millimeters, and it keeps growing each day, adding a millimeter, adding 2 millimeters, like that. Such that by the time of ovulation, this egg is usually about 18 millimeters, 20 millimeters, 22 millimeters. That is the mature egg. So when it reaches that size, it bursts. That is usually around, let's say, day 14 for a woman with a 28-day cycle. So when it bursts, that's what we call ovulation. So once it goes out and a woman is sexually active during that time, there's a chance that they will conceive. But if conceiving doesn't happen, this egg came from a shell, what we call the corpus luteum. So if the person got pregnant, usually that shell supports the pregnancy. It produces some hormone called progesterone, which will stop the woman from going into her period. But if pregnancy didn't happen, this corpus luteum also shrinks and doesn't produce the woman. So eventually, the woman goes in her period. So that's the brief of it. That's the normal cycle. Recruit the egg, grow up to the size of ovulation, which is about 20 millimeters. Ovulate, then from there you either conceive or you have your next period. So what happens with PCOS is, instead of recruiting, let's say, one egg, you find the woman's ovaries are dysfunctional in a way that it recruits quite many follicles, what we call the eggs. Instead of recruiting one, you find your ovaries are filled with about 8, 10, or sometimes even 20 follicles at a go. So the problem with that is your body may not maintain the growth of all these 20 follicles at a go. So they normally grow to a certain size, usually about 8 millimeters, and get stuck there. So you find that none of these many follicles is growing to the size of ovulation, which is 20 millimeters. So they grow to 8 millimeters and then get stuck. That's how you end up not ovulating. And as we look through, when we come to the diagnosis, we shall find out that all these recruited follicles, when you do a scan, you're able to see them on the scan, and it is one of the diagnostic criteria we use. So that is a brief, like the simplest explanation of PCOS. It's a disorder and it affects the ovaries. It is quite common because in women, if you see about 10 women, you may find about 2 of them with that disorder. So, what are the most common presentations? The most common presentations are it affects the menstrual cycle. There's what we call menstrual irregularities. How it affects them is you find you're missing your periods for about 3 months and you're not having your periods. That is actually one of the most common features. The second common features is it presents with what we call androgenic factors, androgenic features in a woman. What we know is predominantly for a woman, it is either estrogen or progesterone. For the men, we have what we call testosterone. The women have testosterone, but in very, very little amount. But what happens when someone has PCOS is you find yourself, you have a lot of these androgens, the male hormones, the testosterone. So what those give you is some of the male features which you shouldn't have as a woman. The common one is what we call histoism, hair distribution. For a woman, you find you have hair where you're not supposed to have it. And most of the time, let's say the beards, you find you have about 4 or 5 beards hanging. And then the other is you find your hair distribution even on your scalp. You find some areas are losing hair. That is also like the male pattern of hair distribution. The other feature is also acne. You find you're suffering a lot with pimples, on and off pimples, on and off, on and off. And then the other feature is when we go to your genitalia, your private parts, sometimes you find there's what we call clitomegaly. The clitoris, you find, is a little bit bigger than what it should be. So those are what we call the androgenic features. Then the other common presentations are you may come in with infertility, failure to conceive. Because remember from our introduction is what PCOS really gives you is it makes you not to ovulate. So conceiving may become a little bit tricky. So infertility is also one of the other presentations. So those are usually the common features. So when you come to us, what do we do? Usually with polycystic ovarian syndrome, you're able to diagnose it. About 70% of the cases, you even diagnose them from the history and from what we see, even before doing any lab tests. But definitely, there are things we normally check for. The common one is a scan. And the scan, in this case, we are concentrating on the ovaries. So there is a picture the scan gives you. You'll find your enlarged ovaries with quite many of these immature follicles. And most of the time, this is how it looks like. So you see an enlarged ovary with those black dots. Those are the immature follicles. So most of the time you find you're able to count about 10 to 20 of them. So that's the scan picture. The other picture we may get on the scan is in regard to your endometrium. The endometrium is that inner lining of the uterus which you shed every month. But with PCOS, remember I said your ovaries recruit quite a number. Instead of one, you find you have about 10 follicles trying to grow. So in that process, also your uterus over-prepares and you find you have a thick endometrium, what we call endometrial hyperplasia. Or the fact that you find you're missing your periods every month, it means each month your endometrium is growing. Let's say you've missed your periods for 3 months. So the endometrium, you measure it and you find it thick. Those are some of the other features we get on the scan. Then usually from the scan, there are lab tests we do. And these lab tests most of the time are hormones. There are quite a number of hormones we can run. But we normally do the basics because hormone tests are a little bit quite costly in our setting. So the most common hormones we do, there's what we call FSH, and that one we run it with what we call LH, luteinizing hormone. We look at the ratio of the two. Usually you find their ratio is 2 to 1. The other hormones is, remember I talked about the androgenic features, the male hormones in a PCOS patient. So we actually test them. The testosterone, there's free testosterone, which we test, and then there's what we call the androgenic index, which we also test. The other tests are still the hormones. We normally want to run the basic hormonal profile, and most of the time this one involves checking your thyroid hormone, checking your prolactin hormone, and also these days, importantly, we have what we call the anti-Mullerian hormone. With PCOS patients, most of the time you find the anti-Mullerian hormone is a little bit way higher than the normal, usually above 3.5. Most of the time you find it is in 9. So that is also some of the tests we do. So for you to be able to diagnose polycystic ovarian syndrome, you need about 2 of these 3 main features. You either have the menstrual irregularities, what we call the amenorrhea, you're missing your periods and they are coming at their own will after, let's say, 3 months or even 5. You have these androgenic features, the hair distribution, hirsutism, and then the scan also is able to show us about 10 to 20 follicles. So any of the 2 features combined with the blood work give us a diagnosis of polycystic ovarian syndrome. So after diagnosing it, what next? From our initial discussion, I've said it presents in so many ways. Either the period is gone, either the hair is too much, or you've even failed to conceive. So how we treat it depends on the woman's goals at that point. Because what I need to mention is polycystic ovarian syndrome is a chronic condition. Once you have it, you have it. It is actually a metabolic disorder. And it even, when you have it, it even puts you at a risk of having type 2 diabetes because they are quite linked. So how we manage it depends on our goals at this time. Do you want to have a normal monthly cycle? includes the androgenic features, the hair, the acne? Or do you want to conceive? Or has it come with one of its complications, the endometrial hyperplasia I told you about? So we treat it according to the goals. And in our next discussion, we shall be looking at the treatment mainly. Thank you. See you next time.